Hello, my name is Roger Henderson. I'm a GP in Scotland and I also co-host the GPnotebook study groups. Welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. And you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook, and you can visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings. Now, in this episode, I'm going to be discussing a common but often misunderstood overuse injury, medial tibial stress syndrome, often more colloquially known as shin splints. So the terminology for medial tibial stress syndrome has historically included many other terms, such as medial tibial syndrome, tibial stress syndrome, and soleus syndrome. But for ease of purpose in this podcast, I'm just going to be using the term shin splints, which is what I think most of us use when talking to our patients about this condition, that we see especially among athletes engaged in repetitive, high-impact activities, such as runners and dancers, and military personnel undergoing basic training. At the other end of the sporting scale, we can also see it in people who are suddenly motivated to either get fit or run a marathon after seeing one on the TV, but who then exercise too hard and too quickly. So first of all, what do I actually mean by shin splints? Well, medial tibial stress syndrome is characterised by pain along the inner edge of the tibia, typically the distal 2/3, and this pain is related to repetitive stress loading of the tibial bone, resulting in a bony overload injury and inflammation of the periosteum, the connective tissue that envelops bones. Now, we should think that rather than being an isolated soft tissue problem, shin splints actually represents a spectrum of bone stress responses. Now, what it isn't, strictly speaking and sometimes incorrectly assumed, a stress fracture, but rather it's a precursor on the continuum of bone stress injury. Epidemiologically, shin splints account for a substantial proportion of exercise-related lower limb complaints. Among runners, for example, the incidence ranges from 13 to 20% approximately, but in military recruits it can be significantly higher, with some studies reporting rates as high as 35% during basic military training. This elevated incidence correlates with abrupt increases in physical load, such as intensified running schedules or unfamiliar training environments. There are also both extrinsic and intrinsic risk factors that can contribute to the development of shin splints. On the extrinsic side, sudden changes in training intensity, frequency or surface hardness can predispose individuals to injury, whereas from an intrinsic standpoint, several anatomical and biomechanical characteristics are notable. And these include a body mass index greater than 30, excessive foot pronation, and we can see this as greater navicular drop on examination, limited ankle plantar flexion range of motion, and increased hip external rotation. Additionally, being female and having a prior history of shin splints are also associated with a higher likelihood of recurrence. There's also emerging evidence to suggest that insufficient levels of vitamin D may impair bone remodeling, which in turn further increases the risk of stress injuries in physically active people in this population. I do think it's important to understand the underlying pathophysiology of shin splints here too, as this sheds light on its clinical presentation to us in our surgeries as well as to its management. So at the microscopic level, the condition stems from the accumulation of unrepaired micro damage in the cortical bone of the tibia, and this damage results from repetitive mechanical loading that outpaces the bone's natural ability to remodel. And so straight away you can see the impact of overtraining here, for example. Compounding this is the presence of periostitis, an inflammatory response at the bone surface, particularly at the sites where muscles such as the soleus, flexor digitorum longus, and posterior tibialis attach. These muscles exert repeated traction forces on the periosteum during activity and contribute to the localized pain. The role of Sharpey's fibers, these are the connective tissue fibers that anchor periosteum to the bone, is also thought to be central in transmitting these mechanical stresses. Diagnosing shin splints hinges primarily on taking a very thorough history and doing a detailed physical examination. And in my experience, patients typically report a dull, aching pain along the medial tibial border that is provoked by physical activity and then relieved by rest. This pain usually develops gradually, initially surfacing after exercise, and then potentially progressing to persist during activity or even at rest in more severe cases. And when it is severe, climbing stairs can also be painful. Now, a stress fracture of the tibia, which is represented by focused discomfort in the front tibia, is the most frequent complication of shin splints. The discomfort gradually lasts longer into the run as a patient's injury gets worse, and eventually it lasts past any cool-down time and into daily activities, and can then localize to become point soreness. On physical examination, tenderness along a broad segment of the posteromedial tibia, typically greater than 5 centimeters, is a hallmark finding. And importantly, the absence of neurological symptoms such as numbness, tingling, or burning pain does help to distinguish shin splints from conditions such as chronic exertional compartment syndrome or nerve entrapment. In terms of differential diagnosis, we do all need to be aware of conditions that mimic shin splints, but which carry different prognostic and therapeutic implications. So, tibial stress fractures, for example, often present with more focal tenderness, are typically less than 5 centimeters in length, and do carry a higher risk for progression to a complete fracture if not addressed. By contrast, chronic exertional compartment syndrome is characterized by tightness and pain during exertion, sometimes accompanied by neurological symptoms, and requires compartment pressure testing for a definitive diagnosis. Vascular issues, such as popliteal artery entrapment or peripheral arterial disease, may also present with exertional leg pain, but these are distinguished from shin splints by the presence of diminished distal pulses or abnormal vascular studies. Now, while shin splints are fundamentally a clinical diagnosis, imaging may be warranted in ambiguous cases or when more serious pathologies such as tibial stress fractures are suspected. Plain radiographs are often the initial imaging choice here, obviously, but it's important to remember that these may appear normal in early or moderate cases. If advanced imaging is needed, MRI scanning is the preferred choice here due to its high sensitivity for detecting periosteal and bone marrow edema that's associated with bone stress injuries. And a characteristic MRI finding that's seen with shin splints is a linear area of signal change in the cortical bone that corresponds to the site of the periosteal irritation. Alternatively, a nuclear bone scan may reveal increased uptake in the affected area, often in a linear double stripe pattern. If you look at the treatment of shin splints, this remains largely conservative, focusing on modifying or reducing the physical activity that incited the symptoms in the first place. There is no universally prescribed duration of rest, though, as the timeline for recovery varies significantly amongst individuals. This depends on severity, underlying biomechanics, and compliance with therapy. Activity modification typically involves substituting high-impact exercise with low-impact alternatives, such as swimming or cycling, whilst at the same time preserving overall cardiovascular conditioning. Adjunctive therapies may offer symptomatic relief, although I have to say the evidence base here does remain limited. Some studies do support the use of modalities such as ice massage, ultrasound, and extracorporeal shockwave therapy, but their benefit does to me appear modest at best. Techniques such as phonophoresis or iontophoresis, which aim to deliver anti-inflammatory agents transdermally, have shown some benefit, but these have only been in small trials. On the other hand, interventions such as stretching, lower leg bracing, compression garments, and low-level laser therapy have not demonstrated consistent benefit in high-quality studies. Preventive strategies are obviously particularly important, especially in populations at high risk for recurrence. So orthotics may reduce the incidence of shin splints, and we presume this is by correcting biomechanical inefficiencies such as overpronation. In refractory cases, by which I mean those not responding to several weeks of rest and conservative treatment, we should reassess for contributing factors such as vitamin D insufficiency or improper gait mechanics. Nutritional optimization and gait retraining, potentially under the guidance of a physiotherapist, can be essential components in the long-term management of severe shin splints. Now, the prognosis for shin splints is generally excellent when recognized early and managed appropriately, and most individuals achieve full recovery and return to pre-injury activity levels with appropriate rest and rehabilitation. So that's the good news. However, delays in diagnosis or failure to modify contributing factors can lead to prolonged symptoms and also an increased risk of progression to a full and true tibial stress fracture. In very rare cases, severe stress fractures may actually necessitate surgical intervention, particularly in high-level athletes or military personnel where return to function is paramount. So just want to précis all this here now. Medial tibial stress syndrome is a multifactorial overuse injury that we should best understand as part of a spectrum of bone stress conditions. Its diagnosis relies heavily on clinical evaluation, and its management should be focused on activity modification and individualized rehabilitation, with rest being the key to the treatment of both stress fractures and periostitis. So that's a good general overview of shin splints, and I do hope you'll find the podcast helpful the next time you may see a patient with this condition. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider leaving a review on your favourite podcast platform and following the podcast. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of all our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.